You talk as a cardiovascular surgeon about how you want to make, heart disease the number 2 killer in the world, not the number 1 killer. But the irony is you had a heart attack. What are the factors that people should be paying attention to? Because this is really a preventable condition.
If a farmer looks out on his fields and all of your crops are sick, where's the first place they look? It's in the soil. Being mindful of what you're putting in your mouth, focusing on a whole foods diet, limiting ultra-processed foods, limiting saturated fats in your diet. You got to be so careful these days with the more extreme choices, because you always have to be careful what you're substituting things for, because it's something that we have such control over.
Yeah. Jeremy, it's great to have you on the podcast. Thanks for coming all the way from Georgia.
Thank you.
Your story is quite compelling. We were just chit-chatting a little bit before. You're a cardiovascular surgeon. You do bypasses and fix arteries and do major big surgeries. Let's say cardiovascular surgery and brain surgery are like the two top surgical specialties that are really tough and hard to learn and take a lot of time to become expert at. And somehow in all that process, you discovered that you were kind of treating things at the wrong end of the stick. You kept seeing over and over cases coming back over and over with bad habits that they never changed and needing another surgery. And you did that for a while, but it sounds like you had your own epiphany in medicine where you realized you might be not thinking about things the way you should. And you had your own health crisis. You talk as a cardiovascular surgeon about how you want to make, heart disease the number 2 killer in the world, not the number 1 killer, which is a great aspiration. But the irony is you had a heart attack. So tell us about that. And you look healthy, you seem healthy. I'm sure you don't smoke. I'm sure you eat pretty good, you look fit, exercise, and you're kind of the kind of person you wouldn't think would get a heart attack. But here you were, and you had a heart attack. And that's kind of what I want to get into a little bit on the show, which is why are so many people who seem and look healthy getting heart attack?
It's an ongoing question for sure. And to make it even more egregious from my standpoint, the time frame between making that shift of treating the endpoint of disease and when I actually had my event was another 10 years later. So I was already very dialed into, really, really working on solid lifestyle choices. And I thought that I was doing a really, really good job. I really did. And what I have come to learn is that none of us are immune to cognitive dissonance. We know better, but so often we just don't do better. It can be simple things. The smoker knows they shouldn't smoke, but they continue. You shouldn't reach for the chips, but it's what's convenient. You're tired. You deserve them. However you defend that. And no one knew better than me.
Yeah.
The signs and the lead up. Yeah. I lived it. I taught it. I dealt with it.
Yeah.
And like I said,
what did you miss?
Intellectual honesty. And I fell deeply into that gap of knowing better and not doing better.
And what were the things you weren't doing that led you to
Well,
that? It was only a few years ago, right?
It was 3 years ago. Yeah. Well, it didn't hit me until after the event, because it was really in the midst of it that I fell kind of first tripped into the space, because I woke up one morning with what I thought was just reflux.
Heartburn.
And I get up early. I was pacing around the room, and my wife's like, "Are you okay?" I'm like, yeah, I get a little reflux. She goes, "You don't look like you have reflux." I'm like, "Seriously, you're going to tell me?"
I'm a doctor.
That I don't have reflux? Come on. So I sat down. I read for a little while, felt fine, took the dogs out for a walk. It was December. We get a quarter mile from the house. It's cold outside. I'm peeling my clothes at this point, sweating. And she looks at me, she goes, "Reflux." I was like, "Yeah, it's just really," she's like, "Okay." So we go back to the house.
Is she a doctor too?
She is not. She's just an incredibly brilliant woman. We get back to the house, and not to be overly graphic, I sit down on the toilet. And within 30 seconds of sitting down, symptoms went away. And I immediately was like, no. Exertional symptoms relieved with rest? No, not me. It's not possible. Couldn't be. Could not be. So at that point, I did what someone who is the poster child of cognitive dissonance would do, and that's explain it away. And through the course of that entire day, I would go upstairs have it come back a little bit, and I'd sit down and it would go away. Oh yeah. That evening, my family went back into town and I was with my youngest son, and we were out in the woods that evening, dark. He's 14 years old, quarter mile from the truck, no cell service. And I go down on my knees with significant chest pain. Like I knew what was going on. And my son's like, Dad, are you all right? Like, what's going on? I said, oh, it's just reflux. He goes, you can't walk around when you have reflux? I was like, oh, you're another smart one in the family. So I pull myself together. We get back to the truck and I drive home.
Oh, man.
Oh, yeah. I'm going to lay it all out for you. I didn't say I was going to be proud. So I get home, I take a beta blocker and an aspirin, and I go to sleep.
Oh, wow.
Wake up the next morning.
Not the right decision, but good thing you woke up.
I share it, hoping that others will do sometimes you need an example of what not to do.
They call, they usually say the first symptom of heart disease is sudden death for 50% of people. And I've had people I know who've had that experience, and you're lucky you had some warning signs. They call it the silent killer, but in your case, it wasn't so silent.
And about 5 or 6 years prior, we had a good friend who was a radiologist at 48 that's exactly what happened to him. So it's not like I'm not aware. I woke up the next morning. We live in a home with staircases, went down to make my coffee, came up, same symptoms. So then I had to come clean. And my wife says, this has been going on since last night. Why didn't you say something? She said, well, you would have made me go to the emergency room. And she's like, well, that's what you do when you're having chest pain. I said, well, I didn't like the cardiologist that was on call that night. She goes, are you kidding me? She's like, you're friends with all of them.
Yeah.
Yeah, and then she stopped for a minute, and I always kind of get goosebumps. She looked at me and she said, that is the most selfish thing you've ever done to me and the boys.
Yeah.
And that hit hard, as you might imagine. And I said, I hear you. I am terribly sorry, but can we go to the hospital? So I call one of my buddies. He's like, there's no way, man. I said, I'm telling you. I said, I've tested it pretty good here. So he's like, come to the office. I'm like, oh, I don't think that's a good idea. He goes, no. Just walking around the office, he took one look at me, and I was in the cath lab, and, one stent in the right coronary, and I was fine. So I wouldn't let him sedate me, for the procedure, because I want to know what's going on. So he passes the wire across it, which occludes the coronary.
And you had severe chest pain.
EKG changes, severe chest pain. And I'm like going, hey man. He pulls the drape. He goes, I need you to shut up so I can get this done. Sedated me, got it done, went out and told Tracy, I dream of stenting cardiac surgeons, but doing anything to your husband was an absolute nightmare. She goes, oh, I'm sure. I'm absolutely sure.
So what were the things that you did that led up to that? Because you obviously have been in this field, you're aware of heart disease, you're not doing the normal bad thing.
It's really only in retrospect now that I was able to really unpack all of that for myself, because the immediate response was, I have a stressful job, and certainly a component, but not enough to really lay your hat on. The second was after 25 years.
And you're still doing cardiac surgery.
Oh, yeah. Yeah. I went back to work that Tuesday after, as soon as they would let me. So, my sleep was totally out of whack. I was on DEFCON 1 all the time. So I was like, okay, that's certainly a risk factor. If your sleep's off, everything's off. Certainly a risk factor. Well, it really wasn't until we started with the platforms, and my son Max was instrumental in all this. He said, Dad, wouldn't it be interesting if you put on a CGM? Wouldn't that be interesting? I was like, Max, if I need to show you what a great job I'm doing with my diet, with my exercise, that's fine. He's like, Dad, I don't care what it shows. I just think it'd be cool, show people, the process and look at your numbers. Yeah. Within 48 hours, it became very clear that my baseline glucose was unacceptably high. Checked A1C. I was 5.7. Flipped into a fasting insulin level, which
was what?
I'm embarrassed to give you the number.
Come on.
I'll say it was,
come on, give it to me.
40.
No. 40?
40.
Seriously. I mean, just for those listening, it should be less than 5. The lab
Thank you,
reference
Mark.
range is 18, which is, I think, terrible. 40 is high. You were what? You had a little belly or what?
You know,
You ate a
not
lot of sugar,
really. No,
bread, pasta, rice,
not
potatoes.
really.
So
And
how come it was so high?
I don't really have that answer, but I definitely retooled my diet as a result of it. You know, using the CGM, I was able to kind of see and I added 10-minute walks after meals. I tried to add more cardio, back off on some of the strength training. I used to do a lot of endurance work. And that made a difference for sure. My A1C came down to 5.5. We got the insulin level down to acceptable ranges. So more risk factors than were obvious. Again, look healthy, but you don't know until you know. And we'll add the coup d'etat on top of it, which would be an ApoB of 180.
Wow. And you had checked it or hadn't?
LDLC only, which was mildly elevated around my event. Mildly elevated. My triglycerides were a little high, which is in line, of course, with the insulin resistance and all those things, but not shockingly so. It wasn't 500. It wasn't in line with that.
What was your triglycerides?
I don't remember. I want to say they were probably upper 100, 200. So
yeah. I mean,
high, but
that's
not.
High. That's high. It should be under 70.
Right. But
so I think the lab reference ranges, would say 150 is
You're not going to cut me any slack today.
No.
Here I am pouring myself out to you to give you an example for other people.
It's amazing. This is important information because you're highlighting the fact that you are a cardiac surgeon.
Right.
You're into functional medicine. You're trying to do the right thing. You maybe had a few things off of your diet, but there was something going on. It could be other factors like your microbiome or toxins that can cause insulin resistance. Sure. But your numbers were numbers that most people don't look at, right? And you hadn't even looked at.
I didn't,
which is amazing. Yeah. And ApoB is now, which is basically a culmination of all the we call atherogenic lipid particles, so triglycerides and LDL particles and, intermediate density particles and so forth, Lp(a). These are all together in ApoB. So it's now recognized by cardiologists as being the most important biomarker for predicting heart disease risk. But it's almost never tested by traditional doctors. It's just they check your regular cholesterol panel and that's it. And yours was a little bit off, but not terrible. Yeah. And here you are sitting on a time bomb and you're lucky you didn't actually have a clot and die. I mean, you could have.
Absolutely. And, it goes back to that you can't fix what you don't measure. And it really took me understanding that my priorities needed to change, that I truly needed to engage in secondary prevention. And to do that, I needed to know what my numbers really were. And the grace at this point is I have now normalized all those things. My particle counts are really pretty phenomenal on Repatha and a little low dose Crestor. And
it's really important what you're saying is because, looking at you, no one would say, oh, here's a high risk heart attack patient. You don't smoke, you don't have high blood pressure, you look fit, you seem to, into health, but these things are under the surface on a lot of people. And we're seeing this a lot with Function Health. We're seeing a lot of people who we're now measuring this on. I mean, I've been doing this in my practice for 30 years. I've been measuring lipoprotein(a), measuring particle number, particle size, even when before that was a company called Liposcience, which did this particle numbers and size before LabCorp before Quest developed their tests. I've been doing this for decades and measuring ApoB and all these numbers. And it's amazing to me that they've been available, but I mean, I sat with the head of the executive physical at Cleveland Clinic, who was an older gentleman who remained nameless. And I was like, listen, I think your executive physical labs are a little dated. Maybe you should do, particle number, particle size, ApoB and all this. He's like, well, we don't like to do things before there's adequate research. And I'm like, well, this has been around for 40 years. Ron Krauss has discovered this 40 years ago. That particle size and number matter, and they track with your carbohydrate intake, not fat. So if you're eating more starch and sugar, you're going to have more of these atherogenic particles. You're going to have high ApoB. You're going to have more particle number and smaller particle size. These are all the things that no one's looking at. So I think, getting these things tested is so important. And at Function Health, that's what we do with everybody. And we're seeing it's huge number of people who have particle numbers that are high. So over 90% have really some degree of abnormality. And when you map it to imaging, then you can actually see what's going on. Sure. And then, you can treat it. You might have some genetic factors. There's lipid genetics that play a role, I'm sure, for you. I certainly have a an inherited familial lipid disorder. It's not like the classic one, but now we have more genetics we can do. I've done my full genetics for lipids, and we're going to be offering whole genome sequencing soon and so forth. Like, I think we're seeing a lot of potential to really understand your unique biology and then how to customize treatments. One thing I've learned over the years is that healthy eating gets a lot easier when you have better options available before you're starving. Whether I'm traveling in between meetings or just getting a quick bite, Paleo Valley sticks are one of the snacks that I reach for most often. They're made with 100% grass-fed and finished beef, organic spices, and unlike most meat sticks, they're naturally fermented instead of relying on unnecessary additives or shortcut preservatives. And just as important, they actually taste good. They're tender, savory, and satisfying, so you're not choosing between convenience and quality. Have a better option ready when hunger hits. Go to paleovalley.com/Hyman to save 15% off your first order today. One of the biggest myths in health and wellness is that younger looking skin comes from what you put on your skin. The truth is that skin is often a reflection of what's happening inside your body. Chronic inflammation, oxidative stress, and poor hydration can all accelerate the visible signs of aging, no matter how many expensive products you use. And that's why me and my team recommend the Radiant Skin Duo from Peak. It combines two powerful tools for healthy aging. Sun Goddess Matcha provides antioxidant compounds that help combat oxidative stress while delivering calm, focused energy without the crash. And the BT Foundation is a beauty-focused electrolyte designed to support deep cellular hydration with ingredients like hyaluronic acid, ceramides, and trace minerals. What I love is that this approach addresses two of the biggest drivers of aging in the skin, inflammation and dehydration. Together, they help support brighter, healthier-looking skin while also supporting energy, metabolism, and overall wellness. It's a simple daily ritual that helps nourish your body from the inside out. To try the Radiant Skin Duo, visit peaklife.com/Hyman and receive 15% off. That's PIQUE life.com/Hyman.
And I think you make some really interesting points. Like, take LP(a), for instance. I mean, it has really been around for decades.
A long time.
And
at least as long as I've been doing medicine.
And if you look at the history of that, of why it didn't come to center stage, and I'd be interested to know what your thoughts are on this, but it was that attitude of, well, we can't do anything about it, so why should we actually be testing for it?
Mm-hmm.
And I mean, that's such a misguided mindset, because, knowing something is as important, even if you can't do anything directly about the thing you know.
Right.
Like having that information so that you can change everything else.
Right. You can reduce all the other risk factors.
Exactly. And even with the inherited factors, the other inherited factors, that's such important information to be able to stratify people that otherwise look healthy, that you need to get those numbers lower, that you need to be more thorough, that you need to be more engaged so that you don't end up in the situation.
Yeah, because I'm sure those numbers that you had, if you've been tracking them for decades, you would start to see the trend line going like this.
For sure.
That's what's available now for people for very low cost. Like at Function Health, we basically do $1 a day. You can get all this stuff done.
Sure.
And twice a year testing and get a really deep view, not just of your your lipids, but also like metabolic health, which is, you're a case in point that most heart attacks today are really, aside from the small subset that's just inherited lipid disorders, it's coming from metabolic syndrome, from prediabetes, from poor metabolic health, where we're eating so much sugar and starch that it's causing high insulin and high triglycerides and high ApoB and all these things that are really from what we're eating.
Things get misconstrued many times because they come in, two patients, right? You have the healthy 50-year-old that has normal standard panel. Physician shakes their hand and says, "You're good to go." And 18 months later, that patient's in the back of the ambulance with a heart attack. And the response is, see, LDL doesn't matter. Cholesterol doesn't matter. None of those things matter. Then you have the other patient that had high cholesterol, was well treated, has LDL levels of a 15-year-old, also in the back of the ambulance 18 months later. And that patient's response is, I was safe. I did all the things. And they're both wrong.
Why?
Well, because the truth is somewhere in the middle, right? Because LDL just doesn't tell the whole story. Now, before, before we attack LDL, clearly LDL is causal. We have lots of data that supports that, but it's not the whole story. ApoB, Lp(a), the metabolic components, that's a very, very important component. The second arm of that is the things we can control.
We've over-indexed on LDL because we have a drug that treats it. The truth is that may not be the right target for treatment. And when you look at the data, like even things like triglyceride to HDL ratio is far more predictive than LDL. And that's a reflection of metabolic health. So high triglycerides and low HDL means you probably are heading towards prediabetes. And that's really the driver. You sort of mentioned people can have normal cholesterol and have a heart attack, or have treated cholesterol and have a heart attack. There was a big study that was like looking at, I think, maybe another study, I think looking at 130,000 people who were admitted to the emergency room with heart attacks. And I think 75% had, quote, normal LDL, but only 10% had normal triglycerides, or something like that. It was like,
it's just not the only villain in the room.
Yeah.
And for most of us, myself included, that certainly was the case, and I think that's the reality. And that's, understanding that we can all fall into this gap, recognizing it before we do, understanding what tools we have available, whether you can move the needle with lifestyle changes, or you do all the foundational pieces, you eat well, you move, you sleep, you have your relationships in check, all those things, and you're still not right, it may be time to consider a different lever. People today think that taking medication is a failure.
No, it's not.
It's not. And it's both the fault of patients and physicians.
Yeah.
I think about it like a scale. At the one end of the patient scale, you've got the individual who's like, just treat me, doc. I'll do whatever you say. And at the other end is, I don't want anything to do with medication. I can do all this myself. Somewhere in the middle is where we need to be. Well, the physician scale is not very different. You've got on one end, the physician that's giving out medication like it's a Pez dispenser.
Yeah.
And I think, honestly,
what's wrong with Pez? I ate that when I was a kid all the time.
It depends on what's inside.
I haven't heard that phrase. You're about my age.
Welcome.
I haven't heard that. I don't know. Do they still make those? I'm like,
I have not seen them, nor have I looked for them.
Don't know what that is. It's a little thing you had when you were a kid. It was like a little device that popped out a little candy, and you could just pop it in. It would pop out a candy. It was like,
and that's exactly how they hand them out. And at the other end of the spectrum, and I think this is actually a much more dangerous mindset for physicians, is we'll just watch this and wait. You're doing great. Continue doing what you're doing with abnormal labs. And the problem is that's like patient-centric care masquerading in this other form. And in the end, these are risk-benefit decisions, right? Like, yes, do the foundational things, do all the things that you need to do. But if that's not working, you don't leave your patient at risk. So both of those things are really at center line is where they belong, somewhere in the middle.
It's true. There's a real need to know what your numbers are and use those to guide you, as opposed to, just you look fine or your basic cholesterol panel is fine. Because that, like you said, for you, yours was a little off, but it wasn't terrible.
That's right.
And I think that's the way it is for most people. And so I think the key here is tracking your trends over time. Because if you were 30 and you track your numbers, you'd probably start seeing them go a little off.
Yeah.
And then by the time you're 40 and then 50 and then, you're getting into your upper 50s, then you really already have the disease. Like you already had a problem. So really you wanted to start checking this earlier, right?
For sure. And I think that my personal mindset is that atherosclerosis is something we have. It's not something we get. If you look at autopsy studies from 3-year-olds, there's a fatty streak in the aorta. If you look at the P-Day study, autopsies from trauma in the field, 18 to 35-year-olds have early changes in their coronary arteries. Now, none of those things are causing any problems at that age, but the propensity for that is already there. Our goal is to get the runway out as far as we can to not have problems. How do we make choices that push our body in the right direction, not the right? How do we stay in that?
That's the thing. So right now we know enough. Like we know enough what to track, what to measure, how to test people.
For sure.
We can talk about imaging a little bit, but we also know that cardiovascular disease is mostly preventable. I mean, I remember learning about William Osler when I was in medical school, and he was the first textbook of internal medicine. He was at Johns Hopkins, this kind of very iconic physician we all learned about. And I remember reading about how when they would have a heart attack patient, it was a huge deal, and they would have the whole staff run, the medical students, the residents, the doctors, the attendings would all come around and see this patient because it was such a rare condition. It was rare to have a heart attack back in 1910.
Sure.
Maybe if you were eating really crappy diet,
which was unusual,
because you could, if you were rich and had a lot of, money, you could buy a lot of expensive, starchy foods, whatever. I don't know. But the point is now it's so prevalent, and we have to sort of be more diligent about actually helping people map out what their history is over time and tracking that. But what are the factors that people should be paying attention to? Because this is really a preventable condition. I mean, you're saying you want to take heart disease from number 1 to number 2. What would be required to do that?
Yeah, I think you started the foundation, and this comes back from my time with you at the functional medicine conference back in 20 years ago. Yeah, it was in Baltimore.
We were young bucks.
Yes. I was going for early morning runs around Baltimore. It tells you I wasn't so smart then either. But really start with the foundational pieces. And I remember a friend of mine said, he was a wise gentleman. He said, if a farmer looks out on his fields and if all of the plants are sick, if all of your crops are sick, where's the first place they look? It's in the soil. What are we feeding the plants? Sit in the airport and watch our fields go by. So I think being mindful of what you're putting in your mouth, focusing on a whole foods diet, limiting ultra processed foods, limiting saturated fats in your diet. You got to be so careful these days with the really kind of more fringe type choices, the more extreme choices, because you always have to be careful what you're substituting things for, right? And so I think that's a great place to start because it's something that we have such control over, right? And I think our gut is such a primary source. Not that we understand the microbiome fully by any stretch of the imagination, but I think the principle really holds. Our what we feed ourselves is the information that we're going to give our body to live on. You can connect those dots. I think most of us can connect those dots. And when you're thoughtful about it, you just feel better. I mean, I've had personal experience with that. Clearly, movement every day is critical, both aerobic training and strength training. They're great independently, but compound dramatically when they're put together. My personal Achilles heel, sleep. I can tell you when your sleep is off, everything is off. And for me personally, it's the hardest because, I can control what I put in my mouth. I can push myself to go to the gym. The harder I try and control my sleep, the worse it gets. So I've had to change my relationship.
What have you done that's helped it?
The biggest things I've done is changing my sleeping environment. Dark, cold, taking a hot shower before bed so that I know that my body temperature is going to drop to help. Going to bed at the same time every night, setting alarm to make sure I'm going to bed at the same time, as well as waking up at the same time, trying to get outside as much as I can just to get sunlight in my eyes. And can I tell you that it's perfect? No. Is it a lot better? Yes. And again, know your numbers. I've been following my HRV, my heart rate variability, which is a wonderful indicator of your autonomic nervous system. Since you are pushing me for my numbers, I will tell you what they were and what they are now. My HRV was running between 15 and 17.
That's low.
And
higher the better.
And now I'm running in the mid to upper 30s. And occasionally I'll hit a 50 if I really am well hydrated. So I'm on the right track, but is it? No, it's not.
It's always a work in progress.
I am definitely that.
So really this whole epidemic of heart disease is largely preventable if you address diet, if you exercise, if you sleep, if you manage stress, if you avoid smoking, if you manage your blood pressure, which also is a big factor.
Absolutely.
And it's very much related to insulin resistance and prediabetes. This whole same phenomena is what causes high blood pressure. So these aren't all separate problems. Blood pressure and heart disease and high cholesterol, they're all kind of one thing.
Nothing happens in a vacuum in the body. It's one big ecosystem.
And so when you start to knock off all these factors, you can start to really change things. And then also, connection, community, stress is a big factor. I think a lot of people are lonely, and that it's like smoking 15 cigarettes a day in terms of its effect on your health. And there's some very interesting studies looking at the gene expression patterns under stress. When you're lonely or isolated, you produce more inflammatory genes expression. So you have more inflammatory proteins out there in your body and causing more damage. And we know heart disease is an inflammatory disease, right?
For sure.
Maybe we can talk a little bit about that, because I think, we used to think that it was just a plumbing problem. You're a plumber, essentially. You're like, oh,
I am.
do cardiac bypasses and open up arteries and fix aortas and fix, femoral arteries and all these things that get clogged up. And so it's kind of like a plumber going in and rerouting the pipes or opening up the pipes and cleaning them out. And the truth is, it's not necessarily just a plumbing problem. It becomes a plumbing problem, but it starts off as an inflammatory problem. And there's ways to check that. So tell us about the role of inflammation in heart disease, and also about how do we measure that.
So I want to separate the roles of inflammation and heart disease, because I think that there is a bit of a misconception in the lay public when it comes to how we think about systemic inflammation versus specifically what's happening at the arterial wall. So when we talk about the inflammatory process, specifically when a plaque or a blockage is forming, the wall of the artery is penetrated by an ApoB-driven molecule, lipoprotein, if you will. That then sets off a cascade of events, one of which is an intense inflammatory reaction in the arterial wall, which draws those inflammatory cells into that area, which then starts this cascade of collection of more cholesterol, a healing process that then starts. And it's that healing process many times where we start to see the actual stenosis forming. So we have a local form of inflammation that's a result of an injury repair pattern, if you will. But the question is, what made the arterial wall vulnerable at the first place? And that, I think, is a distinction that people don't truly understand. Right. So if we break down what's actually happening, there's two components. The artery wall is being attacked, and then it's the integrity of your endothelium, or the intima, the inside lining, that is either capable of fending that off, or it's vulnerable. So it's the balance of those two things. I think that you have to kind of separate what's happening from an inflammatory standpoint, because if you talk to a pure lipologist, they're going to tell you CRP doesn't have anything to do with creating a stenosis. Well, specifically, they're not wrong. You can't, having that inflammatory process in the wall of the artery isn't going to show up on a CRP.
Yeah. But the CRP tells you what the general environment is.
What the general environment is. However, my perception of how to utilize this is it's an indicator of your endothelial resiliency. Yeah. What are the things that are keeping the endothelium intact, that are guarding against those outside forces? And when you have insulin resistance and metabolic syndrome and inflammatory factors, we know that just elevated chronic glucose alone is impacting the vessel wall.
Yeah.
Again, making it weak, making it more susceptible. And that's why it's an equation, really. It's more of a heuristic than it is an equation, because it's more of a guide, just to understand that these are balances. So when we start to talk about those things, like what can we do differently, exactly what you said, how do we put the fire out that is creating this vulnerability that then creates a ripe environment for injury to the wall itself.
Yeah, I mean, I think that's an important distinction between the inflammation happening at the local level and systemic inflammation that sets the stage for things to go wrong.
Yes,
and you talked about insulin resistance, pre-diabetes, insulin resistance, belly fat. That belly fat's producing a whole cascade of inflammatory molecules that's spewing out through the whole body, and is causing havoc everywhere, including on your arteries. And that's that's really, people don't understand that sugar is inflammatory. That sugar and starch are inflammatory, and that's
Sure.
a lot of what's driving. And obviously, it's pollution, it's stress, it's our microbiome. There's a lot of other factors, but that's predominantly what it is. And I think most heart attacks probably before the last 60 years were probably not metabolic syndrome. They were probably different.
Yeah.
They were smoking. They were, people were thinner. They didn't have all this sugar and starch. I think it's changed. I think if you look at it, it's changed. And what's interesting is that doctors aren't measuring insulin, and they're not measuring insulin resistance.
Mine had never been measured.
Yeah.
Until.
And here you are, a cardiac surgeon, and probably the most important predictor of whether you're going to get a heart attack is your degree of insulin resistance, and yet it was never measured, which is just sort of staggering. Yeah. There's actually a new test that we offer through Function Health, which is called the insulin resistance score, which is the most accurate measure of insulin resistance that we have now, other than more of an interventional lab test, which is called like a euglycemic clamp test, which you wouldn't do as in a research study. But it's better than the calculated version we used to call HOMA-IR.
Mm-hmm.
Much, much better than that. And you can now measure using a C-peptide level and an insulin level using mass spectrometry, and we offer it through Function Health. And it's amazing to see how, where people are on the spectrum, and then you can actually monitor it like an A1C and see how it changes.
And I think that that's been one of the biggest limitations with the insulin level is the lack of standardization across labs. What do the numbers actually mean? What's the standardization? So I think to have something that's got some real data behind it's going to be really powerful and something that we can actually count on.
Yeah, it's pretty exciting. So now with the deeper diagnostics, with becoming more affordable, with accessible diagnostics, people can actually know what's happening. And I think people should start early, like get a baseline in your 20s, see what's going on, and I think, the heart imaging era is also changing. So before you'd have to do an angiogram, you have to stick a big catheter in a guy's groin, you have to shoot dye up there, you put a lot of x-rays on, it was a whole thing. And it wasn't that accurate a test. Often you'd miss stuff that was, concentric plaque, or you'd miss some stuff, then they developed like more interesting tests like a CT angiogram, and they now have AI enhanced CT angiograms, which are really interesting. So you can look at soft plaque and hard plaque, and now we can do also a chest and heart CT scan, looking at calcium in the heart. How do you use the imaging, like the coronary calcium score or the AI enhanced coronary angiograms on CT scan? How do you use those?
So I think that this is very much an evolving space very, very quickly. And as you pointed out, it kind of started with the early CT calcium scoring only, then to CT angiogram, et cetera. Now, I will say that coronary angiography is still the gold standard, with FFR measuring actual drop in pressure across stenoses or questionable areas using intravascular ultrasound. I think that there are ways that, again, like the imaging has progressed for the less invasive or non-invasive,
it's also progressed.
It's also progressed on the other side to address the things. So I think these things are complementary. I think that for sure, until we added CT angiography, really knowing soft plaque is so important. Now, knowing calcific plaque burden is helpful as a screening test if you're out totally normal or on the other end of the spectrum. It can get really gray and can really confuse things sometimes in asymptomatic patients without any symptoms that are in that middle ground. It can require further investigation. But as
like a CT angiogram.
Exactly. Yes.
So it's a good screening test.
That's
exactly if it's abnormal, you want to follow up.
Exactly right. And now with this AI component, I think it's going to, when you can digitize the information and you can actually not miss the calculation, it becomes less of a subjective reading and more of an objective reading when it comes to actual measurements. The accuracy, I think, of those tests is going to change dramatically. Now, how is that going to look clinically? What is that going to look like for outcomes? All of those things that's why I say I think it's just an evolving space right now.
And it's important because, I'm sure you've seen patients like this, but, I have patients who have perfectly normal labs, but have plaque and clogged arteries, and people who have even the labs you would expect would be abnormal, or people who have terrible labs and whose arteries are normal. Like,
Yes.
and I'm like, wow, well, you have a high particle number, you have high ApoB, you have high LPA. I'm like, you should be having a heart attack right now, but you're 65 and your arteries are clean. Like,
Yeah.
so I think for me, what it's taught me is that I can't really put people on a lifetime prescription of a medication unless I know the anatomy, because cholesterol is a risk factor. It's not the problem.
Yeah.
It's a risk factor.
Sure.
And sometimes it's high, and sometimes it's not. Sometimes, treating it isn't the real solution, is figuring out what the other causes are and treating those, like insulin resistance.
I think you make a great point. I mean, it's like every decision we make in medicine is a risk benefit decision. And you have to make certain that you're maximizing benefit and minimizing risk, and you're mitigating in favor of that patient. And you can't rely on just one number or even two numbers. Each patient is so dramatically unique and different. Just because there was a pulmonologist who said to me years ago, he said, Jeremy, the protocols are the practice of medicine. Knowing when to and when not to apply those protocols is the art of medicine. And that's what you're talking about.
Yeah.
It's like if you followed the protocols, and there's nothing wrong with that. We all follow the standard of care protocols. Those are our guidelines. But if you plugged that patient into the protocols, you would have put that patient on medication right away without any additional information. If you would but you were thoughtful about that particular patient.
Yeah.
And I think that that's so incredibly important, and one of the things that is of concern for me as I look at medical education moving forward, because there's such a high reliance on protocol-driven medicine, which is wonderful. And
it's the baseline. It's not, but it doesn't go deep enough. Like if
it's a place to start.
Follow the standard protocol, you're not getting lipid fractionation. You're not necessarily checking ApoB. Right. You're not checking Lp(a). You're not checking insulin levels. You're not checking insulin resistance scores. You're not checking all these other things that are so important that have to be part of a full clinical picture to make a decision.
Right.
That's what worries me. It's not that it's not the good starting place. It's just inadequate.
Yeah. Yeah. I think you're right. It's
like
not that it's
medicine
wrong.
Right now is LDL's high, statin. Like that to me is completely screwed up.
It's not wrong. It's incomplete.
Yeah.
I think is the way to look at it. And, at some point, maybe listen to the patient.
Yeah.
Examine the patient, do the things that be a doctor first, and then understand how to put all these things together to make the best decision. Discuss it with the patient, God forbid, and let them be a part of that decision making. And I think that's one of the great things about function health, right? It allows patients to regain a fair amount of agency in their own healthcare. And I think a lot of patients want to do that in this day and age. I think that people are frustrated because access is such a problem. Pick up the phone and try and get an appointment with your primary care physician. It's hard. And I'm not suggesting that it's intentional. They're busy and they're seeing a lot of patients, and it's tough. And I think that to really regain that agency and to take full responsibility for your healthcare, you have to have options to be able to actually follow through with that. And I think that's one of the great opportunities that Function Health offers.
If you're a woman in your 40s or 50s or beyond, I want to talk to you directly for a second. Around perimenopause and menopause, your body becomes much less efficient at building and maintaining muscle. And most women are never told this. They're told to eat less and move more, when in reality, protein needs actually go up as estrogen declines. And that's one reason I use Perfect Amino myself every morning in my smoothie. It delivers all 9 essential amino acids in a pre-digested form your body can use immediately to support muscle and bone health, without adding a lot of excess calories on top of the whole food protein you're already eating. I've also found many people notice fewer cravings when they take it in the morning because their body is finally getting the amino acids it needs. Head over to bodyhealth.com and use Hyman20 for 20% off your first order. That's bodyhealth.com and the code Hyman20. One of the biggest problems with the probiotic industry is that there's often more marketing than real science. You'll see phrases like clinically studied everywhere, but many products were never actually tested in humans or designed to survive digestion in the first place. That's why I've been impressed by Seed and their DSO1 Daily Synbiotic. It's a 24-strain probiotic and prebiotic that's clinically validated to improve regularity, reduce bloating, and alleviate gas by supporting the gut microbiome and strengthening the gut barrier. In fact, DS-01 was studied in the largest clinical trial for a probiotic on bloating and gas in both men and women as of February 2026. That level of scientific rigor is exactly why I joined Seed's clinical board and why I continue to recommend it. Go to seed.com/Hyman and use the code 25Hyman to get 25% off your first month. That's SED.com/Hyman and use the code 25Hyman. It addresses some of the gaps, some of the gaps that are out there in terms of how we're trained as doctors, how we approach prevention. We're kind of in a reactive system, not a proactive system. And think about heart disease. I mean, by the time you have plaque, it's late in the game. When you have like what you had with the symptoms of chest pain and needing a stent, I mean, that's kind of down the road.
Yeah.
And who knows what would happen if you would have found this when you were 35 and you'd done a heart CT where you did a calcium score and you had your ApoB checked and your insulin checked. You're like, oh. And I think that's where we are now in medicine, which is that we have to have more agency as individuals and not just rely on the healthcare system, because the training is going to take a few decades or generations to change. It takes a long time for medicine to change.
It's turning a battleship. You know that better than I do.
Yeah, I tried. I was Cleveland Clinic for 10 years. It was a very big battleship.
Yeah.
And they were very open. It was great. We did a lot of great work there, but it was very hard to get people to change how they think, and to really do more of a proactive approach. I want to sort of talk a little bit about this sort of idea about this person who looks healthy having a heart attack and what you would advise people to sort of check, because for me, like I exercise, my body fat is 10%, I eat healthy, like I shouldn't really have a problem. So why would I bother checking? But actually, I did check. And because of my family history, like everybody, my grandfather's side dropped dead in their 50s. I'm like, I got a problem. So I had to manage it. And I think, I wouldn't have thought I would be a person who would have a high risk, right? Because I've been running since I'm 14 years old. I've been eating healthy my whole life. I've been, yes, I have stress, and sleep issues because I'm being a doctor, and life in general. But it was interesting. So what would you advise people who are listening who think they're healthy? What should they be doing? What should they be checking? What should they know? And when should they start doing it?
Let's start with the simple things first. Get a blood pressure cuff at home and check your blood pressure. If you can't do that, find a friend that has a blood pressure cuff and take it on a regular basis. It's really the silent killer for a reason, because it's not a problem till it's a problem. Most 50% of Americans have it, and many Americans don't even realize that they have it. And it's the most easily modifiable cardiovascular risk factor that we have. And it's just back to that same tenet. If you don't measure it, you don't know. And it's so easy. And doing it once at your primary care visit is not enough. You need the 7-2-2 rule, for 7 days, twice a day, 2 measurements, record them, take an average. That's what your physician really wants to know and what they need to know to be able to come up with an accurate number. So I think that's a great place to start and to really potentially move the needle, because it's such a significant component of cardiovascular.
Blood pressure, yeah. And then blood pressure is not just random. It's caused by certain things, right?
Absolutely.
That you can actually figure out too.
Well, that'll come to the next suggestion. And this goes along with the how we look issue. It's not always your weight. It's the distribution of your body fat. And that's why I really recommend that people are checking their waist to height ratio. Mm-hmm. Very simple to do at home. And that
tape measure is a very cheap medical device.
It really is. Be honest about where it is and where you're measuring
belly
it.
Button.
That's be at the belly button. And you don't want your number to be greater than 0.5. And that's just an indicator, again, of, the amount of intra-abdominal fat, that visceral fat that functions really as an endocrine organ, if we look at it for what it's actually doing. And again, what you're saying, there's drivers of all of these things, and they're also interconnected. So I think those are 2 very simple places to
blood pressure and waist to
blood
height.
Pressure and waist. And then you get down to,
and waist to height would be waist in inches and height in inches.
That's right. Or centimeters in both.
Yeah.
Just keep the units the same.
Yeah.
So that you make sure it's an actual ratio.
It should be less than 0.5.
Exactly. And that gives you something to really follow and track progress, both blood pressure and something that you can do at home. Yeah. You don't have to go to a physician's office. You don't have to do any of that. From there, I think we look at some of the specific labs that I think people should be checking. I think an ApoB is crucial. LP little a, for sure, at least once in your lifetime, because it is a genetic factor. I think that menopause may change those numbers slightly. So I think for women, directed by your physician, it may be best to do it pre or perimenopausal and after menopause as well.
There may be some ways to modify that. There's also new drugs that are coming around that might be helpful for that.
And absolutely. And now they're coming out of phase 3 clinical trials. It'll be interesting to see where those end up, because the question, of course, will be, just because you can lower LP little a, what are the outcome studies that are going to be as a result of that? But story still to be told, and very promising, which is great. I think that's very useful. I think knowing your hemoglobin A1C and some form of fasting insulin is just really, really important. And I think if those are really the core that are not on a standard panel at all, CRP is kind of plus minus. I think there are a lot of primary care who are starting to do it. Those are really not, unless there's some trigger for hemoglobin A1C. They're just not.
Not checking it. They're
just not checking.
They're not checking ApoB.
Mine wasn't checked. So no knock on my primary care physician, because I'm sure
we're just not trained that way. So and these are really affordable tests. I mean, they're all included with all the things you mentioned are included with a lot of other tests, like 160 tests for literally just $1 a day, $365 a year for twice a year testing. It's not free, but it's not that much considering what people spend money on, coffee and whatever they spend loosely money on. It's investing in your health, and sometimes the doctors won't do it. I met with the dean of the medical school in Bentonville, the Dallas Walton School of Medicine, and she's a gynecologic oncologist, and she said she's of Indian descent, from India. She went to the doctor, to a cardiologist, said, "I want you to measure my insulin." He's like, "No," and he wouldn't do it.
Really?
And he's like, "Yeah, well, we know at lower body weights we get more insulin resistance, so like I want to check it." And he was like, "We don't need it." I mean, just that level of this. She said she went to her doctor and said, "I want to get my vitamin D checked because I don't feel so great. I'm tired." So, "You don't need it." She said, "I don't care. I want it." She said, "Well, insurance won't pay for it." Well, she said, "I don't care. I want it." She got the vitamin D and it was 0.
Oh, wow.
Because she was, dark skinned, lived and worked inside,
right.
Didn't go out much, So I think we're missing so much. And that's really why a company like Function Health that I co-founded has really started to give people agency to know what's going on, to not have to be someone like you who's, at 57 has blocked arteries and wish they could have figured that out sooner, right?
Absolutely.
Hopefully your son's getting all those tests.
Oh, and then some. I think he is going to be a lipologist before the end of all of this, I can tell you, because he probably knows more about lipid metabolism and genetics than I do at this point.
Is he in medical school?
He is not.
Oh, okay.
No, he is not.
All right. Now, when I look at skin aging, I'm thinking about it at the cellular level from mitochondrial function, collagen synthesis, cellular repair. And that's exactly why I was interested in red light therapy for the skin. The Bone Charge red light face mask combines red and near infrared wavelengths to penetrate the skin layers and support cellular processes that keep skin looking firm and healthy without chemicals, without needles, without anything invasive. And here's what I love. You put it on, you sit back, and your skin is literally being bathed in wavelengths of light that your cells know how to use. 10 minutes, that's it. I do it while I'm meditating. I get up feeling like I actually did something for my face that day. It's lightweight, it's comfortable, it's low EMF, and it's HSA and FSA eligible, meaning you could just save up to 30% by using money already set aside for your health. So head to bonecharge.com/Hyman and use that code Hyman for 15% off. That's BONCHARG.com/Hyman. If you're like me and tend to sleep hot, the summer months can make staying comfortable at night a lot harder. As a result, I found myself paying a lot more attention to the fabrics I use every day, especially the ones I'm sleeping in. Cozy Earth's bamboo sheet set has been a game changer for me. The fabric is soft and noticeably cooler, so I'm not waking up overheated in the middle of the night. I've also been reaching for their all-day tea a lot lately. It's soft, it's lightweight, and it still feels comfortable even on long, hot days. Sometimes the small things in your life can have a bigger impact on how you feel than most people realize, especially when it comes to comfort and sleep quality. If you're looking to upgrade your daily essentials, head to cozyearth.com/Hyman and receive 20% off. You spend a lot of time like fixing damaged hearts, like literally. And you now want to help people never have surgery. So how do you think about really putting that mission and moving that into the world? Like, coming on my podcast is great. You're writing a book, you have a website, you have a podcast, but like, how do you see kind of doing this for yourself?
Well, I hope that sharing my story and being willing to allow people to peek behind the curtain, if you will, and admit that none of us are immune. It may not prevent people falling into that cognitive dissonance gap, but you will think about it. So my hope is that I can raise awareness, and then by really trying to communicate relatable, high quality health and wellness information that's really tactical in people's lives, and the world that we live in right now is so maximize that everybody feels like they're taking a test. And if they miss one thing on the protocol, that they failed at that. And just give everybody an opportunity to let their shoulders down a little bit, take a breath, and know that if you miss one workout, you haven't failed. You're just going to come back the next day and start over. And to help people really integrate that into their lives, the really foundational pieces, and then helping them understand, well, what's the next layer of that? Okay, you've done the work. Check your blood pressure, check your body fat distribution, check your labs. You can't fix what you don't measure.
Right.
Be proactive about, atherosclerosis, which is something that we know we're born with, something we have. It's not something we get. We get the problems.
Yeah.
Can we keep inflammatory factors at the lowest? Can we keep our insulin levels where they need to be so that we don't have problems at 57 years old?
Yeah, and true. Very true. All right, let's do some rapid fire questions. You ready?
I'm ready.
Okay, so what's the single biggest mistake people make when it comes to heart health?
They think it's not going to be them.
Yeah.
They convince themselves that
I'm fine.
Yeah. It's just not going to happen to me.
That's an important one, because a lot of people stick their head in the sand. They wait till it's too late, and medicine just doesn't seem to focus on prevention. So what's one heart health myth you wish would just go away?
The one that I deal with on a regular basis is that patients that come in with heart disease and get a stent or bypass surgery think they're cured. And I always tell people, we're not treating the underlying problem. All we're doing is getting you out of trouble. You now have to do the work, because the process is still going on.
You think when you crack somebody's chest, they'd change their lifestyle, but often not.
Most of the time not, because I think there's a misunderstanding that they think we've cured the problem.
That's right.
And really all we've done is gotten them out of trouble. We can save you, we can't heal you.
But when you tell them that, do they get it?
It depends. It depends. I mean, I lay it out. I say, if you're going to continue to smoke, all bets are off. We've taken all this upfront risk. I'm not going to soapbox you about smoking. This is your decision. These grafts could be done in 6 months if you continue to smoke. We've taken all this upfront risk for an operation. You don't want to be back to do it again. But I think that's one of the things. It's more of a misunderstanding than it is a myth, but it's become kind of the perception.
What's the most underrated habit for preventing heart disease?
10-minute walk after meals.
10-minute walk after meals. Why?
Because it keeps blood sugars under control.
There you go. It keeps your blood sugar and insulin. Yeah, because your muscles can take up glucose without actually needing insulin, which is amazing. Mm-hmm. But insulin obviously helps. But it's true. I think it's a very simple habit. What's one food you wish people would eat more of?
Fiber.
Fiber. Why?
Well, because it helps control blood sugars. It helps with cholesterol metabolism. It satiates you. And so you eat less. It's not sexy, but...
And it's good for your microbiome.
And it's
critical. I agree with you. It's
critical for your microbiome. I
agree. And the side effects of eating fiber is you're eating a lot of other plant foods. That
exactly.
Are good for. So it's like, how about what do you wish people eat less of?
Saturated fats.
Saturated fats. Okay. We didn't really go into that too much, but there's been a lot of controversy about saturated fats.
Yeah.
And
I'm a believer.
I think I'd love to hear your perspective, because I think my understanding in literature, and also treating, thousands of patients, is that it's so individual.
Yes.
Like I had a patient who was an overweight woman. She had high triglycerides, like 300. Her HDL was like 30. Her, particle number was high. She was insulin resistant. She was pre-diabetic. She had A1C that was up. And I said to her, look, she was struggling with weight loss and just couldn't knock it down. And I said, well, why don't you try a ketogenic diet? And I put her on coconut oil and butter, saturated fat. Her LDL came down 100 points. Her triglycerides came down 200 points. Her HDL went up 30 points. I was like, and she lost 20 pounds and her insulin resistance went away. And she went on basically a ketogenic diet with saturated fat. Another guy was a thin biker. He's like, I heard this keto diet's great. I don't know. I want to try it. I'm like, I don't think you need it, but like, okay, but let's monitor what you're doing. And he was riding his bike 50 miles a day. It was like super healthy and ended up causing his cholesterol to go exactly the opposite direction. High particle number, lots of small particles, high LDL. I was like, wow, okay. So there's a lot of genetics involved here and different people respond differently.
Exactly. And I think that's why following the biomarkers are so important, but my impression is that if we look at the bell curve and we look at the majority of people and how they're going to respond with saturated fats, they're going to fall into a place of concern. I don't know that they're going to fall into those outliers. I think it's more of a risk factor than not, but you don't know till you know.
Okay. What about saturated fat versus sugar and starch? Who's worse? Which is worse?
I mean, I think it would depend on how much of each. I think if you're going to eat only saturated fats, you better follow your biomarkers very closely. If you're going to try to cut out all of those things and you're going to shift to, eating a lot of higher carbohydrate foods, you need to follow there too. You need to be following your blood. I think there's a balance between those two.
Yeah, check your numbers too.
Yeah, check your numbers because we all metabolize differently.
What about non-negotiables in nutrition? It's just like something you never do?
Mine's pretty general. I adhere to an 80-20 plan. I do the best I can 80% of the time, and I know it's not going to be perfect, so I brace myself for 20%. That's my non-negotiable.
And the 20% is what? You're not having Twinkies.
No, I'm not having Twinkies. It's bread or pasta or a piece of cake at a birthday party.
Real food, but not ultra-processed.
Exactly. Essentially removed ultra-processed foods.
I think that should, just for people listening, that 20% should not be soda or industrial processed food.
Yes.
Because those are deadly and they're not actually food by definition.
Right. So, they're edible food products.
I mean, it's true. You look up the Webster's Dictionary definition or Funkin' Wildness of food, it's definitely not what ultra-processed food is.
Sure.
That's defined as something that supports the growth and health of an organism, which none of those things do. What about in terms of exercise? Cardio or strength training?
Individually, they're strong. Together, they're exponential. If you look at the data, the VO2 max and aerobic data is certainly very potent and significant when it comes to decrease of cardiovascular events. There's no doubt about it. We look at cardiovascular health, and when it's measuring how efficient our cardiovascular system is, what does that equate to? That equates to ejection fraction, or how much heart is being pumped out of the heart with each beat. We know that ejection fraction is directly related to longevity and survival. So the data is powerful there in, connect the dots very
On the
cardio. It really is. But when you look at strength training and we talk about muscle and it being the sink for glucose in our body, it's like they're so hard to separate. I get asked that question all the time. And I just, look, we're all drawn to one or the other. I'm working with this woman now. She is an endurance runner and she hates to do resistance training.
Yeah.
I'm like, you have to do resistance training.
That was me. I was 40, skinny, could run a lot, but could bike 100 miles. But
because I
couldn't do 10 push-ups.
and I did the same thing. I was an endurance athlete, and I think that physiologically we're very fit, but mechanically we're not. And that comes to being able to do things as we get older, but more importantly, we know we lose muscle as we age. We know how important it is for our overall metabolism.
It's true. I've indexed way more on the cardio for most of my life. In the last 5-6 years, I've been more on the strength training.
Same.
Okay, what about a piece of advice that every 30-year-old should know?
That it's never too early to start, because the deadlifts you're doing at 30 ensure that you're able to pick up your suitcase at 80. The aerobic training you're doing at 30 is what's going to enable you to, travel and have the endurance to be able to do the things. The decisions you're making now are not going to just impact your overall cardiovascular health, but they're going to change your functional capacity later in life. It's just,
if you want to enjoy the fruits of your labor when you're older, you have to take care of yourself when you're young.
That's right.
I see that often. People run themselves in the ground, they retire, and then they just can't do anything.
That's right.
Yeah. What's one thing you wish every 6-year-old would know?
I would flip that coin around. It's never too late to start exercising either. And we know the data with that, right? We know that you take 55 and 60-year-olds that have never exercised in their life, and you watch how their heart function changes in a very consistent, regimented program, it gets stronger. So it's never too late, but start small.
Yeah.
Make it fun. Pick things that you want to do. Pick things that are enjoyable for you.
I love that story of like the guy at 65 never exercised, starts rowing, and now he's like fitter than most 30-year-olds, like he's 95 years old.
Yeah. Well, and remember too, like particularly in the beginning, that's when they see the biggest benefit.
Yeah.
When you've gone from never exercising to a consistent program, they get a huge, so it's never too late to start.
All right. Now, as a heart surgeon, what's one thing you avoid?
There's so many things. I got to pick one, huh?
Or maybe how about this? What's one thing you avoid that you actually like that you don't want to avoid?
Well, I'm gonna zoom out way far on you. The one thing I avoid is complacency, because I think that that's a very, very dangerous place to be, and I think that's very much where I ended up. Because I felt like I was checking all the boxes. I was doing triathlons. I was competing at the iron distance. I was doing all the stuff, right? But I became complacent in how I evaluated things. And to me, the willingness to change is what allows you to grow and to change paths as the road changes underneath you. So I avoid complacency.
That's good. I like that. I like that advice. And lastly, if there's one biomarker you get to pick as a heart doctor that everybody should check, what is it?
ApoB.
ApoB. Okay. Everybody get their ApoB done.
Yeah.
Okay. Great. Amazing. Well, thanks, Jeremy, for sharing your story. Thanks for your vulnerability and getting other people to think differently about this, because, you've been at the shit end of the stick of the plumbing problem in heart disease for a long time. And I think, waking up to the fact that this is actually a preventable disease, that we actually could move the needle on this, that if people actually knew what to look for, what to do, what to measure, and how to change their habits, that we could actually beat this thing.
Well, thank you so much for having me. I really enjoyed it.
Thanks, Jeremy.
Yeah, man.
If you loved that last video, you're going to love the next one. Check it out here.